In this video, I'm going to talk about three different biochemical pathways, including the purine and pyrimidine synthesis pathway, which is shown right here, the purine salvage pathway, as well as the urea cycle. So starting with the purine and pyrimidine synthesis pathway, you can see that on the right side of the reaction, purines, which include the adenosine and guanosine, are being produced, and then on the left side, we have the pyrimidines that are being produced. Now for this entire pathway, what I would like you to know is to know which enzymes are being inhibited by the medications that I've listed here. So first I would like to start with the hydroxyurea, which is a drug that inhibits the ribonucleotide reductase, and hydroxyurea has been used for the treatment of sickle cell anemia. So patients with sickle cell anemia have problem with their beta-2 hemoglobin chain, where valine has replaced the glutamic acid. And so what happens is that there would be sickling of these red blood cells once they become deoxygenated, and sickle cells will stack on top of each other and cause vaso-occlusive crisis. Now what hydroxyurea does is that it makes the body to form the fetal hemoglobin again. So the fetus hemoglobin is made of the alpha-2 gamma-2 chains, and so once the fetus becomes adult, the body will start to make alpha-2 beta-2 chain. By giving hydroxyurea, body will switch back to the fetal hemoglobin and form alpha-2 gamma-2, and since there is no more beta chain in these red blood cells, therefore there won't be any more sickling, and so hydroxyurea is used for the treatment of sickle cell anemia. The next medication is 6-mercaptopurine, which is used for the treatment of leukemias, and it functions by inhibiting the purine synthesis. So the 6-mercaptopurine is being activated by the HGPRT enzyme, while it's being deactivated by the xanthine oxidase. Now, in order to understand the function of these enzymes, I would like to hold the discussion of purine and pyrimidine synthesis pathway. I will take you back here later on, and for now, I would like to take you to the purine salvage pathway. So here we have the purine salvage pathway, and I've listed some of the enzymes here which you will have to be familiar with and their function as well as their products. So here you can see that the adenine combines with PRPP via the adenine phosphoribosyl transferase. They will form the adenosine monophosphate, and then adenosine would be formed, and via adenosine deaminase, adenosine will be converted into inosine. Now, problems with the adenosine deaminase. If there is deficiency of adenosine deaminase, what happens is that there would be decreased production of leukocytes. And so these patients will develop severe combined immunodeficiency disorder, and this form of SCID is an autosomal recessive. And then you can see that the HGPRT enzyme, which stands for hypoxanthine guanine phosphoribosyl transferase, is the enzyme that helps reverse the hypoxanthine into IMP and guanine into GMP. So what happens if this enzyme is missing is that hypoxanthine and guanine cannot go back in the cycle. So all that this reaction will lead to the production is the production of uric acid. So what happens in patients that lack HGPRT enzyme, it's referred to as Lesch-Nyhan syndrome, and these patients will develop the hyperuricemia, gout, as well as self-mutilating behavior. So again, since these hypoxanthine and guanine cannot be salvaged, therefore there would be increased production of the uric acid, and so these patients present with hyperuricemia and gout. And then one very high yield point with the Lesch-Nyhan syndrome is that they present with the self-mutilating behavior. Like for instance, they start biting their fingers. And it's not clear why patients with Lesch-Nyhan syndrome present with this symptom, but it's a very high yield presentation that you should be familiar with. And then one final enzyme that I have in this pathway is the xanthine oxidase, which, as you can see, converts the hypoxanthine into xanthine and then xanthine into uric acid. Now, allopurinol is a medication that will inhibit the xanthine oxidase. So you can see if we inhibit the xanthine oxidase, no more uric acid can be produced. And so this medication is used for the chronic treatment of gout. Okay, now that you know the function of these enzymes, let's go back to the table here. So here we have the 6-mercaptopurine. It's being activated by the HGPRT enzyme. So patients with Lesch-Nyhan syndrome cannot activate the 6-mercaptopurine drug. And then 6-mercaptopurine is also being deactivated by xanthine oxidase. So what happens in these patients is that if you also prescribe allopurinol will block the function of xanthine oxidase, and thus there would be increased toxicity of 6-mercaptopurine. So keep that in mind. If you prescribe allopurinol and 6-mercaptopurine together, there would be increased toxicity of 6-mercaptopurine. The next medication is 5-fluorouracil, which inhibits the thymidylate synthase enzyme, and 5-fluorouracil is used for the treatment of colon cancer, breast, pancreas, as well as stomach cancers. If you use the 5-fluorouracil in a topical form, it can also be used for the treatment of basal cell carcinoma. And so, as you can see, the function of 5-fluorouracil is to inhibit the synthesis of thymidine. And the toxicities of 5-fluorouracil include photosensitivity, as well as myelosuppression. And so if you want to reverse these side effects, what you can do is that you can provide thymidine in these patients, because that's actually the product that is being inhibited by the 5-fluorouracil. And then the next two medications are methotrexate and trimethoprim, which inhibit the dihydrofolate reductase enzyme, as a consequence of which, again, there would be decreased production of a deoxythymidine monophosphate. And so methotrexate is used for the treatment of rheumatoid arthritis as well as leukemias, and it can also be used for abortion in patients that have ectopic pregnancy, while trimethoprim is a bacteriostatic drug that is being combined with the sulfonamides to treat different conditions, like for example urinary tract infections. The side effects of methotrexate include the myelosuppression, stomatitis, fatty changes of the liver, as well as megaloblastic anemia. And so what you can do is that you can reverse these effects by providing these patients with folinic acid, also known as leucovorin. So you know how methotrexate inhibits the dihydrofolate reductase, so you can provide them with the folinic acid to reverse the toxic effects. Now, however, if you have a patient that has overdose of methotrexate and you will have to get rid of the drug inside the body, then you can provide them with bicarbonate. And the reason is that methotrexate is a weak acid, so once you give bicarbonate, it will help methotrexate get eliminated in the urine. And then side effects of trimethoprim include anemia, leukopenia, as well as granulocytopenia. And so what you can do is that you can again provide leucovorin for these patients to help reverse their side effects. Okay, now we are done with the discussion of both the purine and pyrimidine synthesis pathway as well as the purine salvage pathway. So now we can move on to the last topic, which is the urea cycle. And so here you can see that two of these reactions, the carbonyl phosphate synthase 1, which is also the rate limiting step of the urea cycle, is being taken place inside the mitochondria, and then ornithyl transcarbamylase is also another reaction that takes place in the mitochondria. And then the rest of these enzymes are all in the cytoplasm. Now I would also like you to know that urea cycle can be connected to the TCA cycle via the fumarate. And then from the purine pyrimidine synthesis pathway, you may recall that carbonyl phosphate could be converted into orotic acid, which will form the UMP via the uridine monophosphate synthase enzyme. And the UMP will be converted into UDP and continue to go on until it forms pyrimidines. So the final point I would like you to know is that how does the inhibition of the carbonyl phosphate synthase 1, ornithyl transcarbamylase, as well as uridine monophosphate synthase will affect the levels of NH4 as well as orotic acid in these patients. So starting with the carbonyl phosphate synthase 1, this is the enzyme that will combine ammonia with carbon dioxide to form carbonyl phosphate. So what happens when you inhibit this enzyme, there would be backup of NH4, so the concentration of NH4 increases in these patients, and then there won't be any increase in the concentration of carbonyl phosphate, so the level of orotic acid does not increase. With ornithine transcarbamylase, what happens is that reaction will keep on going to the other side. So since it cannot any longer enter the urea cycle, the reaction will keep on going to the production of the orotic acid. So orotic acid will increase in these patients. And since the reaction cannot enter the urea cycle, which is also connected to the TCA cycle, the levels of ammonia also increases. And then finally, if we have defect in the UMP synthase enzyme, what happens is that there will be backup of orotic acid, so orotic acid increases, but then the NH4 can still go into the urea cycle. The other pathway is not affected, so it's still connected to the urea and TCA cycle. So the level of NH4 does not increase with the uridine monophosphate synthase deficiency. So now you can see that if you know the function of these enzymes and their products, the entire pathway, you would be able to interpret how deficiency of any one of these enzymes will affect the levels of NH4 as well as orotic acid. Now, if by any chance on the exam you get confused and you're looking for a memory aid, then the memory aid that I have for you is that carbonyl phosphate synthase is the one that is closest to NH4. So the level of NH4 will be increased with deficiency of carbonyl phosphate synthase 1 deficiency. Uridyl monophosphate synthase, on the other hand, is closest to the orotic acid, so deficiency of this enzyme will cause an increase in orotic acid, but no changes in the ammonia. And then finally, we have ornithyl transcarbamylase, which is in between the two reactions. So deficiency of this enzyme will cause increase of both NH4 as well as orotic acid. So deficiency of ornithyl transcarbamylase increases both NH4 and orotic acid. So now we can go through this table and fill it together. So how does deficiency of these enzymes affect the level of ammonia as well as orotic acid, and what are the clinical presentations of these enzyme deficiencies? So carbonyl phosphate synthase 1 was closest to ammonia, so there would be an increase, but no increase in orotic acid. Uridine monophosphate synthase was closest to orotic acid, so there would be an increase in the level of orotic acid, but not the ammonia. And then finally, ornithyl transcarbamylase was in between both reactions, so there would be increased level of both. Now, as for the clinical symptoms, these two first enzymes, they would increase the level of ammonia, as a consequence of which patients present with convulsions, coma, and death. While with the uridine monophosphate synthetase, there would be a normal level of ammonia, but orotic acid is being increased, and at the same time there is decreased pyrimidine synthesis, because we need to form UMP and then UDP and then pyrimidines from this reaction. So if the conversion of orotic acid into UMP is blocked because of the deficiency of uridine monophosphate synthetase, there would be low levels of pyrimidines, as a consequence of which there is problem with DNA synthesis, and so these patients present megaloblastic anemia, failure to thrive, and early death. And that concludes our discussion of the purine and pyrimidine synthesis pathway, purine salvage pathway, as well as the urea cycle.